Hi, everyone. Welcome back to Clinician's Brief, the podcast, where we bring you the conversations behind our clinical content. I'm the host of this program, Dr. Alyssa Watson, and in today's episode, we're going to be talking about a challenge that we as veterinary professionals often face in clinical practice, and that's managing fearful, anxious, or stressed pets that also happen to have a comorbid disease process going on. Joining us once again is Dr. Tamara Grubb, anesthesiologist, pain management expert, president of the International Veterinary Academy of Pain Management. Dr. Grubb's an award-winning educator. She's the owner of an anesthesia and analgesia consulting company, and she's been on the podcast before, so we are super thrilled to have her back on the show. Inspired by her recent interactive quiz, which is called Managing Fractious Patients with Comorbid Disease, and you can all find it at cliniciansbrief.com, today's conversation is going to explore practical strategies for handling just a range of patients. We're going to be talking about things like a painful and anxious hit-by-car dog, or that spicy kitty that comes in with osteoarthritis, but also maybe has some kidney disease. So Dr. Grubb, welcome back. It's so wonderful to have you again. Would you take a minute? Yeah. Could you just reintroduce yourself quickly to our audience and let us know what you've been up to?
You bet, and thank you for having me back. It's so good to be back and get to share information with everyone, especially with this tough topic, because I know a lot of people are afraid of sedating patients, especially patients with comorbidities, and we're going to have to get over that. So I think you introduced me really well. You covered all of my angles: anesthesia, pain management, private practice, academia, consulting. So just like most veterinarians, I think I probably wear too many hats, and my most favorite hat right now is being, as you said, the president of the International Veterinary Academy of Pain Management, or IVAPM. And that's been my dream job. So very happy to be the president. And what I've been up to, I'm probably a broken record because I'm sure I said the same thing last time. I'm always up to the same thing. Pretty much my passion, my mission is educating, especially pet caregivers, but also all members of the veterinary team about what pain looks like in animals, so we can find it and get those animals out of pain. So it's my mission. It was yesterday, today, and it will be tomorrow too. And next time I'm on the podcast, probably the same.
Awesome. That's so wonderful. Well, let's jump right in because I loved this quiz and you hit all of these, really important clinical scenarios that, just like you said, I'm a little bit fearful of. And I know I could be a lot better at offering these animals not only, good pain management, but also, like we said, anti-anxiety, managing that mental pain that we know goes along with being afraid and kind of that situation being in the vet office. This first clinical scenario is one, it's like every single day, and that's that anxious or painful small breed dog, the Chihuahua with a heart murmur that also really doesn't want you anywhere near its mouth. And these are always, while you're in the middle of your exam, the owner is like, well, can you just check the teeth really quick? And so my first question for you is, when we have a patient that does have heart disease, what are the main risks associated with really forcing that examination or administering really high doses of sedatives without preparing, the team and the patient first?
I'm really glad that you asked that question because it's something I think we don't think about. When we're afraid of sedation, we're going to stay away from sedation. We need to remember what the stress response does to the patient. So when we are having to wrestle that patient or really restrain it excessively, and we activate that stress response, and just think about a stress response in general, all of the things that happen. So in this particular patient, the most problematic are tachycardia and hypertension, and the stress response in a healthy patient can be detrimental. But here we have a patient that already has some of these factors, and so now the stress response can actually make the disease worse or make some of the components of the disease worse. We're amplifying that tachycardia and that hypertension. So thinking about what not sedating is doing to the patient is what we should do if we're afraid, and also communicating that to the pet caregiver, who often says, I don't want my pet sedate. no, I'm the doctor, and it's worse to not sedate. So we're going to do that. So not sedating is obviously a problem. And then you're right, the high dosages, we want to make sure that that patient is as calm as possible, that we sedate as early as possible, because the high dose of most drugs, including sedatives, are more likely to cause adverse effects again. So we don't want that component, the adverse effects. So preparing the patient for a calm visit really gets us around away from uh, a lot of that, hopefully all of that, but certainly it puts us in a better starting place.
Yeah. You also mention in the article that kind of simply allowing the stressed patient to just like calm down, as we would say, we're going to leave you in the room, for 10 minutes or so with your owner. That often isn't effective in these cases. Can you share a bit more about why maybe stepping back and actually going home and starting from scratch, addressing a lot of this anxiety through medications before the next visit will make such a big difference in our outcomes?
Yeah, absolutely. And I observe the same thing that you just described. That very often, if they're already anxious in the hospital, unless we give them a sedative and wait for the sedative, but just waiting for their behavior to change, some they're just a little excited, a little scared. Okay, maybe. But most of these, and especially ones with high fear, anxiety, stress patients, those aren't going to get any calmer. They're still in the hospital. They're still in the hospital. They don't know what this building is, but they know it smells funny and there's lots of loud stuff and someone keeps coming in and poking at them. And so there'd be really no way for the anxiety to decrease. So like as you mentioned, just starting over and sending that patient home with anxiolytics to be administered at home, coming in another day with the anxiolytics on board, and just giving that patient really a better experience, a better, calmer experience. That's the best way to start. And it makes everything safer. A calm patient, when we're talking about sedation and anesthesia, a calm patient is a safer patient.
When you are choosing those anxiolytics for, a patient that's very similar to this, we'll stick with this small breed dog that we know is going to probably need some teeth extracted or something. What are your key factors that guide the decision between all the options we have? Because we actually, especially in dogs, do have a lot of options, gabapentin, trazodone, even a combination of some of these things.
Absolutely. And then there's things like the transmucosal dexmedetomidine, and there's the chill protocol. There's a lot of really good choices. And well, okay, let me just back up. A lot of really good choices. We're dealing with unpredictable patients, so we're probably going to get unpredictable responses, but we have a lot of choices to choose from. How's that? So for me, it really comes down to the veterinarian who's administering those drugs, their comfort level. Which one do you like the most? Which one do you feel in your hands gives you the most consistent response? And that's the one that you should choose so that you know what to expect in that patient and know how to escalate the level of sedation or anxiolysis if that particular protocol didn't work. I use a lot of gabapentin. It's the one I'm most familiar with. And because it can also decrease chronic pain, doesn't have a big effect on acute pain. But since it can decrease chronic pain, I kind of get a win-win situation in the patients with underlying pain. But really, any of these are good options.
Okay. Are there any that you would particularly stay away from? I mean, you had kind of mentioned the chill protocol in this particular patient, where we, like we said, we have a heart murmur, we might have some underlying cardiac disease, or maybe we have, we're thinking we're going to need general anesthesia because there is a tooth that needs to come out or something like that.
Yeah, for this particular patient, the chill protocol does include some oral transmucosal acepromazine. It's a low enough dose that I would be comfortable with it if that is the protocol that the veterinarian chose that they were comfortable with. I would stick with my gabapentin and maybe add in a little trazodone if they need it because that's the one I'm most comfortable with. But dose dependent, that ACE wouldn't concern me, but I could see picking something else. And as far as uh, you said, because anesthesia is going to happen, then we definitely want some kind of protocol. And again, whichever one works for that veterinarian works for anesthesia. Because I mentioned it already, but when we have low anxiety, like low fear, anxiety, and stress, it's safe for anesthesia. because now we need a lower pre-med dose of the sedative. And again, the drugs mostly, adverse effects are mostly dose dependent. And then that just goes into a calmer induction, usually more stable maintenance, a better recovery because the anxiety is low. So any kind of calming anxiolytic protocol that that patient needs really will have a major positive impact on anesthesia.
Yeah. So I'm hearing it's okay to go ahead and prescribe these, even if we don't know what the rest of the day is going to bring, and actually probably is going to help us out if we do need general anesthesia.
Absolutely. I completely encourage it. And, there's that old country song, something like, I was country when country wasn't cool. I feel that way about anesthesia. Anesthesiologists loved calming before calming was cool. Right now it's all the rage. Good. But just dealing with those calmer patients again is a safer patient. So not only is it okay to give the anxiolytics before anesthesia, it's encouraged. And a lot of our patients get a little care package to take home. They might start their analgesics at home, maybe an NSAID. They'll start their anxiolytics, maybe an antiemetic, right? All of that the morning that they're coming in for anesthesia.
Perfect. Let's move on. We're going to talk about the next clinical scenario that you present in the quiz. This one's less common, certainly, but one that I've seen multiple times, and it's a little bit more urgent. And that would be the anorexic cat that you suspect hepatic lipidosis, but this kitty really won't let you handle it in order to place like an IV catheter. I certainly have been practicing long enough where in the beginning of my practice, we did things like boxing down animals. Can you walk us through why boxing down or even, mask induction might seem really tempting because, we want to get to where we need to get fast with diagnostics, but actually might pose greater risks to both not only the patient, but also to our team.
Absolutely. This is a big topic to address, and I'm really glad you asked because I don't know that everyone realizes the danger to the patient and the team. And I understand why it's still tempting. And I'm like you, I learned that back in vet school. But if I look at the drugs that we had back then, we had acepromazine as a pre-med, and we used it the label dose, and they slept for days. We didn't have a lot of good options for sedation and induction. And now we have a lot of options. There's just really no need to revert to that. And the thing with the patient, the danger to the patient, is that there will be a stress response, whether we're holding them with a mask or whether they're tumbling around in the chamber. They're getting they're having behavior changes. They don't know what's happening. They often go through an excitatory phase through that inhalant induction. And so the stress response of that, back to the stress response, tachycardia, hypertension, hyperglycemia, all of the adverse effects of that stress response are happening to that patient with this slow induction. So that's danger number one. Danger number two is it's a really high dose of inhalant in that chamber or in that mask to make that patient go to sleep. And the adverse effects, we've already said this about drugs, are usually dose dependent. Inhalants for sure. So by the time the patient is asleep, now it's hypotensive, it's probably uh, not breathing very well. So really, that's danger number two. So there's just really no reason to put the patient through that. And then the staff, we know that chronic exposure to a lot of chemicals, including inhalant anesthetics, can cause health effects in humans. And usually more people that may be prone to having some issues anyway. So, like one of the things that can happen is a little bit of immunosuppression, and that's more likely to be in a patient that maybe is immunosuppressed that day anyway. Maybe you came to work with the flu, and so that can exacerbate underlying disease. We know that in people that are susceptible to some types of migraines, the inhalants can cause migraine headaches. We don't know the effects on reproduction, this chronic exposure. Don't want to know with my staff. And so there's just enough health dangers to the staff that it's just a wrong thing to do for our staff. Even if it was the right thing for the cat, which we've said it's not, it's wrong for the staff. So we should not be doing that anymore.
And then you mentioned we do have just so many more options, than, in fact, back when I was in school, we were still using halothane as a gas anesthetic in our, and so, these reversible sedatives, particularly the alpha 2 agonists, they've just been fantastic.
Yes.
Why are they preferred in this situation? And then how do you decide with these combination protocols? We can mix these drugs with opioids. We can mix them with benzodiazepines. Do you have a set kind of formula, or what kind of cases are you using those in?
You know, sort of a set formula, but one of the fun things about anesthesia, if you like anesthesia, is it's a little bit of an art, right? The science, we know the drug, we know the dose, but can we mix it with another drug, put in a little blue paint, a little red paint, right? So the art is fun and we can kind of make it patient dependent, but still a baseline protocol should be what we're using so the staff is familiar and we're familiar. So with the alpha 2s, I really love the alpha 2s. They are potent, they're fast acting. You can give a low dose and get a calm patient. You can give a higher dose and get a really almost outpatient. We get some analgesia. They're reversible. So, what's not to like about alpha 2s? I think it's a great class of drugs. Of course, I'm being a bit facetious because not every patient is appropriate for an alpha 2. But the ability to give an IM injection in this fractious cat and get good sedation, so we don't have to wrestle the cat. And especially in this cat, because we are going on to anesthesia, right? This cat is getting a feeding tube in our scenario, so there's no reason to wrestle it to try to get an IV catheter. Let's just sedate it IM. We're progressing that direction anyway. And so giving it the IM drug, getting it calm, and then the reversibility in this cat was a big part of my decision because with the hepatic lipidosis, if the liver can't clear the alpha 2 agonist, we can just take it back, right? That adds to the safety factor of the alpha 2 agonist. So that's why I chose a reversible drug, a potent reversible drug. And then you're right, we can utilize combinations. Since this cat is going to have a painful procedure, we would definitely add an opioid for sure. So we want that analgesia. And plus, we know just from experience and from research that when we combine an opioid and an alpha 2 together, we get a more consistent response, so a more consistent level of sedation. So that's all good too. Adding in things like the benzodiazepines, we certainly could. The alpha 2s are anxiolytics, but not as potent anxiolytics as the benzos. I am more likely to use the benzos as part of induction, so with the propofol or alfaxalone, because remember, using them as pre-med, some patients could have paradoxical excitement, and so we definitely don't need that in this cat that's already excited. And in this cat in particular is throwing another kind of wrench in the works here, in that because it has hepatic disease, the benzos can sometimes be problematic in those patients. And so this cat's got the triple whammy that I would stick with the opioid and the alpha 2.
Perfect. And then we can get him down, we can get blood drawn, everything we need. And like you said, pop the feeding tube in, which is, I have found that was another thing. I don't know. I just was hesitant to do early on in my career. And now I'm such a pusher of feeding tubes. As soon as they stop eating, I'm like, we got to get this feeding tube in because this is what turns them around right away.
Doesn't it make a difference? And I'm like you. I back things I didn't learn about anesthesia. I'm the
Mhm.
same way. Things I didn't learn about feeding tubes, and it seemed like it was just this big thing. And now it's like, oh, it's a cat put in a feeding tube and needs it. So yeah.
Looking to protect your canine patients against parasites? Look no further than Simparica Trio, Serolaner, Moxidectin, and Pyrantel chewable tablets. The first chewable to offer triple protection from heartworm disease, ticks and fleas, and roundworms and hookworms. It's also FDA approved to block infections that may cause Lyme disease by killing deer ticks.
Use with caution in dogs with a history of seizures. Serolaner belongs to the isoxazoline class, which has been associated with neurologic adverse reactions. The most common side effects were vomiting and diarrhea.
Visit SimparicaTrioDVM.com for full prescribing information.
Okay, so I'd like to shift gears just a little bit. We're going to go to another scenario that's really familiar to general practitioners, and that is that senior kitty, probable osteoarthritis pain, painful senior kitty, but we've also got chronic kidney disease, at least early chronic kidney disease. You point out that oftentimes pain is one of the major drivers of fractious behavior in these kitties. So, how often do you think we miss pain as an underlying factor in cats like the one we just talked about?
Yeah, and that reactivity, that when dogs or cats reactivity or isolation, a cat that used to be friendly now wants to bite, a cat or dog that used to be friendly now hides under the bed, those behavior changes are indicative that something has happened if that's not the way the cat always was. And it's often pain. And just think, hopefully you've never been painful. But if you have, maybe you were grumpy. I know I'm grumpy when I'm painful. And so that's what our patients are going through as well. And grumpy pets don't make very good pets. So we see this reactive behavior very often related to pain. And I think we miss it I know we miss it a lot. And if we look at statistics, I'm just going to pick osteoarthritis as an underlying cause of pain because it's the most common cause of chronic pain. And we know that about 40% of all cats probably have some pain related to osteoarthritis. When those cats reach 6 years of age, 60% likely have that osteoarthritis pain. When they reach 90%. And I don't know about you, but I know in my practice, I'm not diagnosing 90% of cats over 9 with chronic pain. So using our statistics, we can see that we're missing a lot of cats. And it's not because we're bad veterinarians. It's because they don't come in for pain, right? Because the pet owner doesn't know what pain looks like in their cat. That's why it's my mission to change that. So they don't present for pain, and we're busy. We're getting all the things done that fit into that exam, and we don't always ask the right questions. And then the other thing is, I think sometimes we don't have our ears quite open and we don't listen to that behavior change scenario. The dog is suddenly biting, the cat is suddenly hiding under the bed, and go, wait a minute, something's wrong here. Let's investigate. It may not be pain, but still it's something we can help with. So, a long story with maybe some boring statistics, but just we are missing it a lot, but not because we're bad veterinarians, but because we're not getting them in there for pain.
So we really need to be considering pain and then taking that seriously and treating it with, either, some sort of analgesia medication, NSAIDs, cats with NSAIDs. There's a lot of hesitation there, and I want to talk about that. But also, again, with these new medications, there's these new, anti-nerve growth factor monoclonal antibodies that we have available to us. Can you walk us through how you decide between specifically those two options in a cat that has early stage kidney disease?
You bet. Great question. And good for I'm glad you're asking it that way and everybody's listening to it that way. We have two options. We have options for pain management, and leaving pain management out is not one of them.
Not
Not fair to the cat, not good medicine. And I know with all diseases, sometimes we are hesitant to treat if we don't have the exact perfect option. But doing nothing, especially with pain, is just as wrong as making a choice that maybe isn't perfect, or more wrong, really, leaving that cat in pain. So both are good, and both the NSAIDs have both the NSAIDs and the anti-nerve growth factor monoclonal antibody have been shown to be safe in cats with that early chronic kidney disease. So I think either is a really good choice for the analgesia. They're both very potent analgesic drugs. And so for efficacy, either are a good choice. I'm going to choose the anti-nerve growth factor monoclonal antibody for compliance because people are bad at medicating cats. I'm really bad at orally medicating cats, and especially when it has to be done every day, like the NSAIDs. And even with good cats, sometimes we forget. I don't mean good cats, I mean easy to treat cats. All cats are good. Easy to treat cats, sometimes we forget. Not all cats are easy. So I want this cat who's now showing a behavior change because of pain. That's big. I want this cat to have pain relief. So with the anti-nerve growth factor monoclonal antibodies compliance, we give the injection, right? 100% compliance. So I know that cat gets its drug. Whichever one you choose, we need to make a recheck appointment, though. Make sure they're coming back. And for the anti-nerve growth factor monoclonal antibodies, we do, because they have to come back for their next injection. Sometimes we forget to do that if it's the NSAID. So whichever one you choose, make a recheck so that we know that the drug is working.
And then how do you handle client communication with something like the black box warning on, meloxicam for chronic use when we're using it in this situation?
Yeah, that's really a tough one. And it's, what is that? I don't know the answer. Maybe you do. I think none of us know exactly where is that line between too much information that we scare the client and not enough, and they go home and read it on the internet that we're killing their cat because of what we prescribed. I don't know the middle part there. Um, the good thing with NSAIDs in cats is we also have robenacoxib, and so that one doesn't have the black box warning for cats. It's not FDA approved for use in cats with chronic pain. So we still have to have that discussion. It's approved in other countries, both meloxicam and robenacoxib. But that does also lead to the choice of the anti-nerve growth factor monoclonal antibodies. That's the only drug that is approved in the US for treatment of, in this case, osteoarthritis pain. So it makes the conversation easier as well as the administration.
There are some things that we can do for these kitties outside of medications. You really mentioned the importance of environmental modification. So are there some simple, like high impact changes owners can make at home that can help these cats?
Absolutely, and I'm glad you put it that way. Simple and high impact. This shouldn't be hard. We can really help these cats with just some little changes. And the environmental modification is important for two reasons. One is just mobility. If the cat's painful, it needs to not have to get in places that are difficult. And then also for quality of life, which we all want. So little changes like making sure, and I know this seems like common sense, but if you haven't had to think through it as a cat caregiver, then it's not common sense because it's not common to you yet. But just making sure that the litter box and the food and the water live on the same level of the house that the cat lives in. The cat shouldn't have to go upstairs to eat if it has underlying musculoskeletal pain. That's going to be worse. And then also making sure the litter box isn't a giant that has to do some gymnastics to get into the litter box. That's really not going to help pain. And then giving the cat a way, a means to get back to its happy place. Where did that cat like to be before it was painful? So the example for a lot of cats, it's a sunny window. But now maybe that cat can't jump up in that sunny window again, and it just sits at the bottom just staring up. I'd like to sit there. Let's give that cat some joy in life and make it a little ramp, right? So that it can walk up to the window. It doesn't have to jump. Or a kitty tree that's not so high. It can be a lower kitty tree. Something to put that cat back where that cat wants to be. And those just little changes can make huge differences for the cat.
I absolutely love those suggestions. I do kind of want to circle back to what we talked about, what you talked about right at the beginning was oftentimes these cats aren't presenting for pain because the owners don't recognize pain. So do you have any, when we recognize pain, do you have any talking points to get those owners on board? Because sometimes I've found that they are hesitant, to make even little changes like you're talking about, or do a daily medication, like you said, especially when they think, the cat, oh, seems fine.
It is amazing, isn't it? Oh, he seems fine. Or still eating, doc, so it can't be pain.
Mm-hmm.
Or limping, but that's not pain. You see, we've heard them. We've heard them all. And I'm with you. Sometimes it's a big struggle. And I don't know that my tips are any better than anybody else's. But what has worked for me in some cases is to mirror what they've said to me. So you just told me that your cat is grumpy now, and it didn't used to be. To be really friendly. What you're describing to me, what you're seeing in your cat, can be a sign of pain. So let's investigate that. So really bringing it back to their cat. What did they see in their cat? And then also bringing it back to them as a human. And we started our conversation this way about, okay, Mrs. Cat Owner, cat caregiver, whatever they prefer to be called. Have you ever been painful? You were probably grumpy too. So you can see why your cat might be grumpy. So bring it back to them. And then trying my best to get them to try an analgesic trial, which is, again, often why the monoclonal antibodies are a preferred choice because they're not having to participate. We get the injection, they don't have to give any oral medication, and then we see them again in a month. And so I'm trying those things, but I'm with you 100. I don't have a 100% success rate yet, but mirroring what they're telling me at least gets them to see their cat.
And I think that that's another place, just like you said, where that recheck comes in. Because I have had that where I said, well, let's try it. Let's come
Yeah,
back in a month and let's see what happens. And the change, once they've opened their eyes and are looking for it, can be really obvious.
I agree. It makes all the difference when then, okay, oh yeah, now I do see now he's jumping back up to the kitty tree, or now he's not grumpy anymore. It really, I'm with you. It's a game changer when we tell them what they need to see, and I give them a little checklist of what to look for, and then they see that now they're convinced. And I'm glad you brought the recheck back up, because we make a recheck if we start them on heart meds or kidney meds or anything. We make a recheck. And yet for pain, unless we're giving the monoclonal antibody, the recheck is for the injection, we're not making rechecks. So got to have that recheck.
All right, we're going to move on to our final clinical scenario. This one is going to be the urgent one. This is that really intense situation. This is you get a call. The front desk calls back and says somebody's on the phone. Their dog's been hit by a car. We know that in these situations, sedation is going to be just essential for the patient safety, for the staff safety, and handling the pain for that patient too. Why is it critical to sedate these trauma patients early, rather than waiting as these things escalate? Why does our team need to get that crash cart there?
Yeah, that's a good way to put it. And I I tried to choose scenarios that were kind of maybe not every day, but I wanted everybody to think about it. And then scenarios like this, where this happens to us, maybe not every day, I hope, but often enough that everyone has had this scenario. And it is so important to get those patients sedated right away. They come in, they're often scared to death, they're painful, and they probably weren't fractious to start with, but we've all seen those reactive dogs where they're so painful and so scared, and we're coming at them, and the only thing they know to protect themselves is to try to bite us or to try to flee. That's a horrible situation for that patient. So when we see that they are, of course, if the trauma is so bad that hemorrhage is the biggest problem or airway is the biggest problem, all right, we're addressing that. But in this scenario, it's getting that patient where we can handle it, so that we can work on the problems. So sedating it right away, obviously it's going to need sedation. We're not going to be able to take x-rays. We're not going to be able to handle it. This is obvious. And so for the patient, lowering that stress, let's sedate right now. We've talked about the negative impact of stress. And just again, for safety of the handlers too, that dog's trying to bite us. It's really scared. So it's for our safety and the dog's safety. And this has happened to all of us too. If we wait to sedate until that dog is so worked up that it's really the behaviorally, it's just we can't handle it at all. It's harder to sedate them. It takes a much higher dose to overcome all those excitatory neurotransmitters. And I know I've mentioned it like 6 times now, but because the adverse effects of most drugs, including sedatives, are dose dependent, now that we're putting that patient in danger because it's a higher dose, but we have to do it. So if we do it early, it's the right thing to do by the patient, get that stress response lower. It's the right thing to do by our team. It's safer. And then it's safer for the dog because we can usually use a lower dose to accomplish that sedation.
Yeah. It is truly amazing the amount of drugs that a really, hyper anxious dog can blow through. I swear I've used more drugs in a dog than when I used to practice on horses.
Right. And sometimes that's all that will work. And it's unfortunate because then it is scary. It's like, I don't want to give this much, but
Yep.
we're obviously not getting where we need to be. And then back to your one of your early questions too. This is also where we want to utilize more than one drug. So adding in that opioid for pain relief and more consistent sedation and things like that. But still, it takes such high dosages.
Mm-hmm. It does. You also, though, have some really practical tips and kind of wonderful techniques for administering sedation, particularly things like IM injections safely, in these big dogs. Could you talk a little bit about that for our audience?
You bet. And I think probably in everybody's practice, there's a nurse or a technician or multiple nurses or technicians that are way better at it than I am, because that's where I learned my tricks on how to handle these patients, and just safety first. And so if we can gently get a basket muzzle on a dog, that makes such a big difference. Now we know we're unlikely to get bitten, and that's really important. It makes us less reactive too, right? I don't know about you, but if I think a dog's going to bite me, I'm usually jumping away. So a basket muzzle is really nice. Or even if you can't get something on the face, just a cone of shame. Here we can use the cone of shame to kind of direct the dog's head away from whoever's giving the IM injection. So again, for safety, the anything distracting. So those little popsicles that people make with the frozen meat broth, or even a little cheese or peanut butter, something to distract them. That can be great. And it's just a tiny amount, right? So we're not feeding them in case we need to anesthetize them. It's just a little bit. And then one of my favorite techniques, maybe not in this trauma dog that was just hit by a car, but just a reactive dog, is to have, especially the bigger dogs, is to have your best technician put a leash on that dog and start walking the dog with purpose. We're moving a little bit fast here. And then we come along behind the dog. We have our sedative drug in a syringe, and we have a butterfly catheter on there on that syringe, and then put a little bit of air in the syringe. And as that technician is walking with that dog, you pop that butterfly catheter into the epaxial muscles and then start injecting. And the air is to flush out your butterfly catheter. And that's why you want your best technician on the head, because when that needle goes in, whoo, got to keep walking that dog. And it's amazing how well that works. And so it's one of my favorites.
Yeah, I'll remember the very first time I did the walking stick,
Yeah,
and
I love that.
it truly is a game changer.
Isn't
So,
it? And it's so not like squishing the dog behind the door to the exam room
right.
and all that
Oh
kind of
yeah,
stuff.
no, I remember those.
Yeah.
Yeah, yeah. Using the exam room door as a squeeze chute is not optimal.
No, no. Usually doesn't work very well. And then unfortunately, as we all know, because we've all done it when we didn't have other tricks, then it's a losing proposition a lot of the time.
Mhm,
They're so worked up by that point that
mhm.
it's
Yeah,
really tough to get anything to work.
yeah. So if you can't get that IM injection in, when, if you need to use something like an oral transmucosal sedation, what signs do you watch for to assess whether that sedation is deep enough to proceed? Because that's another thing I've found with some of those meds is I think that the animal is sleepy, but then they still will jump up and snap.
Right. Oh, yeah. I don't like those surprises. And you're right. Sometimes we have to go oral transmucosal, and your description of the scenario is perfect. They're very useful, but we're not getting the magnitude of effect that we do when we inject. So we really want to be cautious as you're describing. So just gently asking them, touching them, using gentle touch, gentle approach, saying, how are you feeling? And not touching anything that's painful. And I'm probably describing the scenario everyone uses, but I'm going to go through it anyway. So just gently touching and then maybe slowly approaching to the painful side, keeping that basket muzzle on though, just for safety for us. And if they're reactive at any point that we need to be at, so we really need to explore that wound, then now's the time to give them more sedation. So topping them off right at this point is now we can easily get an IM injection or maybe even a catheter in a back leg or something and go IV. But if I'm asking them just gently and there's any inkling that we're not at the right place, then I'm going to go on to the next step, more sedation or even induction, and just make sure everybody's safe and that we can do what we need to do for that patient. So yeah, everybody be careful because we've all done that. We think they're sedate and they go, ow, and oh, that was bad.
Yeah,
We don't
yeah.
want that.
Well, that actually kind of leads really nice into my final question, the final topic I want to talk with you today. And that is, I have seen a lot of veterinarians commenting, in social circles and on social media that they are seeing, or at least they feel like they're seeing more fractious, more stressed, more aggressive patients. And then there was just this recent study out of Texas A&M that used that dog aging project data. And I mean, it just made huge headlines because it said that over 99% of dogs had at least one moderate or serious behavior issue. So given all of that, do you think it's appropriate or even necessary sometimes for a veterinary team to actually deny care in order to protect themselves or even protect the patient from injury? And how do you talk to a client about that?
Oh, those are tough, aren't they? They're really hard because not only talking to the client, but even just for us, we didn't go to veterinary school or veterinary technician school to refuse care. Like that's just so against what we want to do. But I do think sometimes, yes, we have to. We have to be able to do our job and to not have injuries. So we have to, as we've been talking about with the sedation, it's as much for us as it is for the pet. And in this emergency scenario that we just talked about, okay, no, we're not going to refuse treatment, but we are going to say your dog will be sedated or I can't do anything, and if we can't do that, well, we're just going to do that. So maybe we got to do something for that dog. But for the rest of them, yeah, I certainly try not to refuse. If we can start with some behavior meds, start with some gabapentin at home or some trazodone at home, if they're interested in a behavioral consult, if they'll let us sedate them as soon as they come in, right? If they're working with us, then I'm willing to work with them. The problematic ones for me are the owners that say, no, I don't want you to sedate my dog. And we can't deal with that dog in a safe way. And again, not safe for the dog either. If the owner could see the stress response in the dog, they would want, I think, would want their pet sedate versus us wrestling the dog. And so in those patients, if they truly are a danger and the owner will not allow sedation, I personally think we have a very valid right to refuse because somebody on our staff is going to get hurt if it's us or one of our technicians. And I don't think we should have to take that risk when the owner is refusing our medical recommendation.
Well, that brings us to the end of all of my clinical questions. This has just been a great conversation, but we still have one quick little thing. I don't know if you remember from the last time you were on the podcast, but do you remember our rapid fire game?
I do, but I forgot the question, so I may not have
Well,
answers.
see, no, I went back. I was like, I should ask the same questions and see if she gives different answers, but then I didn't. I wrote you all new questions.
Okay, good, because I don't want that look into my psyche. I don't know what it would mean.
All right, but you are up for playing again.
Yep, let's do it.
All right.
It's fun.
Here we go. Would you rather consult exclusively on surgical emergencies or only complex medical mysteries for an entire month?
Oh, I'm a complex medical mystery person.
Okay. All right. Would you rather invent a painless injection device that's compatible with every current drug that we have, or discover a new anesthetic class that has instant onset and minimal side effects?
Ooh, that's a hard one. But I'm going to go for the painless injection because I think we have a lot of good drugs. It could always be better, but that could be impactful right now. Whereas the new anesthetic, it's going to have to be researched and it's going to have to be proven and it's going to be a while before anyone can use that. So I'm going for the painless injection. And I want it to.
I like that. And I want it now. Okay. Would you rather practice without trazodone or without gabapentin?
I want it all. So I want both. But if I had to eliminate one, it would be the trazodone. And again, it's because of the gabapentin's role, not only in anxiolysis, but it's an adjunct drug for chronic pain. We got a little bit. I think we gave it a little bit too much credit for how good it is at chronic pain before we had the anti-nerve growth factor monoclonal antibodies. We had NSAIDs and then nothing else. And now we have two choices that are more potent, and gabapentin is back to an adjunct drug. But because it plays two roles, I'm keeping my gabapentin.
I figured you were going to say that after listening to a lot of your answers today. All right. Would you rather star in a reality TV show about veterinary medicine or perform a live stand-up comedy set about anesthesiology?
Oh my goodness. Both of them are like public scrutiny, which is, I'm actually an introvert. I don't come across as it, but I am. I guess I'm going to go with the stand-up comedy because I'm in control. In those reality shows, everyone seems to be out of control. And so as an anesthetist, maybe there's a little bit of control freak. I'm going to keep you asleep safely. So I'm going for the comedy routine. I'm scared
Yep,
of
I
it
would
though.
go for the comedy routine too because I just like to get up, get it over with, and then I don't have to think about it anymore.
Yeah, those are really good reasons to do it. Yeah.
Okay, final question. Would you rather anesthetize 10 kitten-sized T-Rexes or one Tyrannosaurus Rex-sized kitten?
Oh, 10. Hmm.
Itty bitty
You know,
ones.
it's a tough one. It's a tough one because I'm going back and forth between I love knocking down horses, making a big horse fall down safely. Like everybody goes, whoa, that's amazing. So I really like that aspect, but I like kittens too. But I'm gonna go for the big one just
The
because I'm gonna show off
big,
and go, I can do this.
giant kitten. I love
Yeah.
it. I
The
love
little
it.
5 foot tall anesthetist, I can do it.
You're going to climb on a ladder.
Exactly. Yep. Yeah, maybe put a rope around his neck and swing from it as I'm trying to go for the jugular there. See what's
Well,
wrong
that
with
was a wonderful, that was a wonderful visual image, and I'm glad that's how we're wrapping up today's conversation. But for everybody at home, thank you so much for listening. You want to make sure you check out Dr. Grubb's article. It actually has a really wonderful table of medications and dosages, and it'll break down advantages and disadvantages of a lot of the drugs we talked about today in these different situations. So thank you so much for joining us again, Dr. Grubb. You're always welcome here. We can't wait for you to write some more, and so we can have you on again.
Oh, thank you very, very much. I can't wait to come back again. And just the final tip, and we started with this a little bit earlier, but the final tip for everyone using those drugs and those dosages, remember, in these high anxiety patients, we're dealing with unpredictable patients, and so sometimes we get unpredictable responses. And so they're not perfect, but should give you a leg up on decreasing anxiety in your patients.
Thank you for listening to Clinicians Brief the podcast. If you enjoyed today's episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcasts on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@instinct.vet. Clinicians Brief the podcast is an Instinct Science production, produced by Alexis Ussery and hosted by Alyssa Watson.